Hi, good afternoon, everyone. Thank you for joining us today. My name is Andrea Bonacci. I'm the Director of Population Health Programs with Adirondack Health Institute. This is the second to last presentation in our 2021 North Country Leadership Summit, emerging from a year of change and an opportunity to rebuild and reimagine. The summit is being brought to you by AHI and Fort Drum Regional Health Planning Organization. And I would like to thank our many sponsors for supporting this year's summit. A few housekeeping items before we get started with our next presentation. Just a reminder that this is the last day of summit. So after this next presentation, we have one more presentation at 2 o'clock. Please be sure to place all of your questions and comments in the chat box, and our staff will ensure that your questions are answered during a Q&A session at the end of the presentation. All attendees will remain muted with videos off during the presentation to ensure best broadband connectivity. And all presentations will be recorded and archived on the North Country Leadership Summit webpage by October 1st. So I'd like to hand it over to our presenters for this session. We have Sarah Healey Herod, Melissa Hatcher, and Joseph Aquilino, and they will be presenting ER on Demand Northwell Brings Telehealth Home. So I will mute, turn off my video, and hand it over to your team to begin the presentation.
Thank you, Andrea. We'll just take a moment to get the slides up. And Joe, just... All right, awesome. So, perfect. Thank you again, Andrea. So good afternoon, everyone. Thank you for joining us today. My name is Melissa Hatcher, and I'm joined by my colleagues, Sarah and Joe, as Andrea mentioned. So the goal of today's presentation is to tell the story of the last 19 months and how Northwell took a program, a telehealth program born out of crisis, and turned it into a thriving care delivery model with direct lines to 10 patient populations across New York State. We'll start the story off with an overview of our organization and introduce the interdisciplinary team responsible for implementing and maintaining this program. From there, we'll talk a little bit about our COVID response, the EMS telemedicine initiative and its evolution, and then we'll wrap it up by describing what we hope to achieve with the program as it matures. For those of you that don't know us, Northwell Health is New York's largest healthcare provider, serving New York City, Long Island, and Westchester. As an organization, we strive to provide compassionate care through research and innovation. I'll leave this slide up for just a moment so you can take a look at our size, scope, and economic impact. Okay, Joe, thank you. In addition to being New York's largest healthcare provider, we're very proud of the national recognition we've received. My team, the Centralized Transfer Center, is a division of Northwell's Center for Emergency Medical Services. Northwell CEMS is the largest hospital-based ambulance service in the New York metropolitan area. Prior to the creation of our EMS telemedicine program, my team's primary focus was the coordination of all aspects of the interfacility patient transfer process. Our partners in the emergency medicine service line are responsible for overseeing the clinical, financial, and administrative operations across Northwell's 18 emergency departments, where there are over 850,000 ED visits annually. Initially, the service line supported us by providing physician coverage. But by the end of this presentation, I think you'll see how their partnership helped to expand the size and scope of this program into something that was able to benefit multiple patients across the state. So now that you know a little bit about us, let's get into what you really came to hear about. In February 2020, the president declared COVID a public health emergency, but there weren't any reported cases in New York State at that time. Then came March. COVID hit us hard and fast. 4 weeks after our first reported case, our ambulance reached its peak call volumes. Looking at this timeline, you can see that within 2 weeks, from March 15th to March 29th, our call volume increased by over 1,000 calls. Our hospitals were also exceeding capacity, and on March 21st, we began load balancing. We transferred over 810 patients from our hardest hit hospitals to facilities in our network with the capacity to treat them. At the same time, the Fire Department of New York's 911 system was experiencing a surge in call volume, and the agency contacted nearby health systems for assistance with triage and treatment. Northwell CEMS responded with a proposal detailing our plan to modify our existing ambulance triage process to screen callers and connect them with the appropriate care. Our proposal was accepted, and the EMS telemedicine program was formed. We used our existing emerging infectious disease surveillance tool and the Protocol 36 pandemic screening tool set forth by the International Academy of Emergency Dispatch to effectively screen patients, directing callers appropriate for telehealth to telehealth services. We held our first kickoff meeting on March 19th and received our first phone call less than 2 weeks later on March 31st. If anyone is interested in learning more about our screening process and its efficacy, be sure to check out our paper in the Journal of Pre-Hospital Emergency Care on the utility of the emerging infectious disease surveillance tool. Okay, so why the emphasis on telehealth? By now, you know that there were thousands of calls queuing in the NYC 911 system. In addition, not only were our hospitals exceeding capacity, but other hospitals in the region were exceeding capacity. Our urgent care partners, their centers were also overwhelmed, and there were extremely long wait times for in-person emergency visits. So it was very important for us to be able to find a way to connect patients with care, but without overburdening the current system, since it was already at capacity and there really wasn't anywhere else to be able to send these patients. So now that you understand the why, let me show you the how. This screening workflow was the first iteration of our EMS telehealth program. When patients call 911 in New York City, they're briefly screened by an FDNY operator. And then patients that are deemed to be low acuity are then transferred to our team of paramedics for additional screening and connection for treatment. We used, like I mentioned, we used our existing ambulance triage process to direct callers to one of 3 endpoints. And I should mention that the process map that you see on the screen shows our various levels of escalation. So what you see in the top row is where the caller is initially referred to, but if that service is unavailable, then it moves down to the next subsequent row. So the 3 endpoints that we directed our callers to was immediate telehealth with one of our physicians, scheduled telehealth with one of our GoHealth urgent care partners, or we would provide an ambulance response or an EMS response. EMS responses were activated whenever directed by the screening tool. So if a call was received and based on the details of the screening, it was determined the patient was in some sort of acute crisis and they needed to be transferred. That's what we refer to our Delta and Echo category. You see that at the top of the process map. Those are usually patients that are unconscious or having some type of cardiac arrest event. If the screening tool deemed that that patient was in some type of acute crisis, we would dispatch an ambulance. There were also instances where patients would refuse the telehealth services and they were adamant that they needed to go to the hospital. So we would also send them an ambulance. And lastly, if we weren't able to connect the caller to care in a timely manner, then we would have to send an ambulance. But that last one, we didn't have to do too frequently. Eventually, the workflow was modified to include support from our emergency communication nurses who are trained to address and provide guidance for non-life-threatening situations. We also removed the scheduled telehealth appointments with our GoHealth partners because, similar to their walk-in volume, their telehealth volume was surging, and it was proving difficult to schedule patients for appointments. So now that we understood our population and we had a process in place to triage our patients, we were faced with our next challenge. How do we operationalize this in a way that we could train our paramedics quickly while also maintaining the other initiatives we've been tasked with? We often joke and say we stood the program up with duct tape and popsicle sticks. As you can see on this slide, our key technologies are made up of 6 different systems that aren't exactly designed to work together. CAD is our computer-aided dispatch system. This system is mainly used for dispatching our ambulances. The CAD system houses ProQA, which is our ambulance screening tool. It assesses the patient and determines the appropriate ambulance resource to respond. This screening tool is overseen by the International Academy of Emergency Dispatch. Next, we have IMS, or our Incident Management System. It's a custom-built software that acts as a decision support tool, and it allows for a consistent call-taking experience and the ability to change logic-based workflows with minimal training. It also provides us with the capability to collect data for detailed analysis for tracking and trending the metrics. So the ProQA and the not really ProQA, but the IMS system was instrumental for us because we were able to do a lot of just-in-time education. As our paramedics went through their form and their workflow, there were instructions that would be right in line so they knew what to do and how to proceed. Our REDCap system is a secure web platform for building and managing online databases and surveys. We used REDCap similar to how we used IMS. However, REDCap does contain advanced alerting capability, which was essential for us to work in conjunction with Power Automate. Amwell is our telehealth video platform, and Microsoft Teams is our Teams communication platform. And like I mentioned, Microsoft Power Automate, that's a powerful automation tool, and it really is the backbone to many of our workflows. So all of our work, looking at the screening tools, figuring out how to modify them, and then also evaluating the different technologies that we had available to us, all of that culminated into this final EMS telemedicine workflow that you see on your screen. This slide shows you how the systems work together. We start by screening the caller using CAD and IMS. And once it's been determined that the patient is a candidate for telehealth, our paramedics complete a demographic intake in REDCap. REDCap then sends a message that is received by Power Automate, and Power Automate takes the contents of the message and automatically posts them to a channel within Microsoft Teams. This allows the rest of the team to see what's happening, and they can interact and respond right in one central location. All of our communication is done within Microsoft Teams. Once the patient is registered and scheduled for the visit, the physician joins them in the Amwell virtual room to complete the telemedicine encounter. I think what's most impressive to me looking at this slide now is that all of this work was done in 2 weeks. This workflow, with some modifications, is still in place today. So now that you understand the genesis of the program, I wanted to just wrap up with giving you a little bit more information about some of the barriers that we've encountered and solutions to some of those problems along the way. So I laugh a lot when I see Faith, but Faith was a big thing. People told us we couldn't do it. I mean, how could we stand up an entirely new practice in the middle of a pandemic while we were already stretched thin trying to maintain normal operations and load balancing? But the team welcomed the challenge. We were just starting to see the impact of the CTC, or the Centralized Transfer Center, which was something that had also failed previously. So we were ready to embrace the next mission. Plus, it was the right thing to do for our patients. We saw what COVID was doing to our own hospitals. So we wanted to participate in a program to assist with navigating patients to the care that they needed without further overwhelming the hospital system. Another barrier that we faced was resources. And really, it was around staffing. So some of our paramedics came out down with COVID and they were out sick. And again, my team was also very stretched with load balancing and helping with some of the other operations. We're also a very small administrative team, so we didn't have the bandwidth to expand the program once we were able to identify opportunities where we can help others. Time. During wave 1 of the pandemic, everyone was stretched so thin. So we were decompressing hospitals, dealing with employee absence and sickness, and then people were fighting their own personal battles. It was definitely a tough time, I think, for everyone involved. On top of that, we were traveling down an uncharted path. There was nothing, there was no playbook. So we were really figuring out things on the fly and just doing our best to make things happen. And I think, resources and time, one of the solutions that we found, again, was our partnership with the emergency medicine service line team. With their guidance, we've really been able to grow and help patients that we never imagined reaching before. And then lastly, well, I shouldn't say lastly, we spoke about, we have technology that didn't exist and we had to put together those 6 disparate systems and try to make them work. Even our telehealth platform, Amwell, at the time was only being utilized for in-hospital telemedicine, and it was fraught with issues. So our paramedics became experts at troubleshooting, and we really became experts at figuring out workarounds for making that technology work. And then lastly, billing. Once we had everything set up, how do we get paid? There was really no precedent set for telemedicine billing, emergency telemedicine billing. And I think Sarah and Joe would agree that we're still trying to figure out what's going on in the billing area, but we've come a long way and there's still a lot of work to be done, but it's been a great journey. So now I'm going to turn it over to Joe so he can tell you a little bit more about the program and where we're going to go from here.
Yeah, thanks, Melissa. You guys can hear me okay?
Yep, Joe, you're good.
Awesome, thank you. So where do we go from here? So as Melissa was just talking through all of our 2020 accomplishments and all the great work that we did in 2020, we saw an opportunity to expand and really create something bigger. So in 2021, we introduced a concept called Northwell Emergency Telehealth Services, which we call NETS. So a little bit about NETS here. So as Melissa mentioned, we started NETS due to factors related to COVID, recognizing the need to serve the community and leverage idle providers during a time when individuals needed care but may not know how to seek it. NETS is bringing care to people where they feel the safest, which was at home. So with the aid of the public health waivers and support of the payers, NETS aims to serve the community in a way that the emergency medicine field was never able to do before. So a little bit about the makeup of NETS. It's a 24/7 telehealth service provided by Northwell's Emergency Medicine Service Line and Centralized Transfer Center. NETS is unique compared to other telehealth services because our staffing model is completely made up of board-certified emergency medicine physicians, which is a group of 12 dedicated individuals and have a dedicated portion of their practice to telemedicine. During the beginning phases of this program, we did work with EM physicians who were taking telehealth calls as part of their practice while working in the EDs. But as we moved over time and as we progressed through COVID, our volumes in the EDs began to rise to the normal levels, which made it difficult for our emergency medicine physicians to take those telehealth calls, which kind of gave birth to our 24/7 physician coverage model, which is ran by those 12 dedicated physicians I was just mentioning. So a quick little overview about the process. Patients who use NETS will speak first with a paramedic for a clinical triage. Then we'll navigate to the emergency medicine physician if their condition is determined not to be life-threatening. So if it is life-threatening or if it's not appropriate for telehealth, our paramedics and physicians have the capabilities to escalate to our our EMS service if an ambulance, of course, is needed. So a little bit about our workflows. So as Melissa mentioned, we created this nice, easy to follow workflow in 2020. Pretty straightforward. But once 2021 hit and we introduced this concept of nets, we realized that it needed to be a little bit more integrated and a little bit more involved. As we worked through the timeline, we realized, hey, let's add pediatric emergency medicine physicians, which is in that third swim lane there. So making it, as you can see, a little bit more involved, a lot beefier, and a little bit more difficult to follow. So of course, once we decided to go to that 24/7 coverage model, we had to incorporate even more steps, making it even more convoluted. And then of course, we started introducing more programs, several, which I'll go over in a bit, several of our programs. This is our house calls overnight program, which also all included all these workflows. So overall, it was just a lot of workflows involved. So we realized that we needed to come up with something simple, something basic, something down and dirty and to the point. So here is what we created. This is our NETS process. It's a 4-step process that we have, which has 4 primary disposition points. So let me just run through each individual disposition. So of course, a physician could refer the patient to the ED if necessary. Patient can also be referred to a specialist, which our patient access services team will follow up with the patient the next day to set up an appointment. Prescription medications, if appropriate, are prescribed to the patient and of course can be sent to their preferred pharmacy. We also can send to 24/7 pharmacies, and we actually also have a at-home delivery service available to our patients as well, where our Northwell team will deliver medication to the patient's home. And finally, which is about 50% of our dispositions, at-home remedies, over-the-counter drugs, anything that could help the patient through the night. And about just a quick little factor in there. So about 10% of our patients, we do refer to the ED. So what is our patient population? So it all began in 2020 with FDNY. So that laid a great basic framework for what we introduced in 2021, which is our direct-to-consumer program, ER On Demand. So once we had all of this in place, we realized that we could start introducing all those other different populations. So as you can see here, we now serve several populations, some in-house, some are direct-to-consumer, which we'll touch upon in a bit. So here are some of our program offerings. I'll just call out a few here. We market that patients are seen within an hour of calling, but our average call to provider time is approximately 20 minutes of initial call. If the patient does in fact need further care, we have the capability to direct a patient to an ambulance, as I was talking about before, if needed. And if the patient does decide to go to a Northwell ED, we are capable of calling ahead to the ED to alert them that a patient is coming. Patients are easily connected to our referral services, and if further specialty care is needed, they're contacted within 24 hours, as I was mentioning before, our relationship with our patient access services team. And I think one of our biggest patient satisfiers is our next day follow-up process, which is essentially one of our ED physician, or our telehealth physicians calling the patient the next day, just to kind of checking up to see if they're feeling okay, see if anything further is needed on their end. So we love our data in emergency medicine and with the CTC. So here is just some data points that we've been collecting through the NETS program. I'll start with the top left. So volume by month, as you can see, we've been steadily increasing our volume from the beginning of January through today. As you can see, there's a slight dip in June, but Sarah will kind of get into that a little bit when she takes over here. Median age is 38 years, but it's pretty evenly distributed through the rest of those brackets there. We've seen a patient that was 2 weeks old all the way up to a 101-year-old patient. And our most common chief complaint we have is UTI, but as we started to introduce more and more programs over the past several months, it's kind of evenly distributing out to other chief complaints as well. So that 21% is about a quarter of our patients. So we want to particularly focus on one of our programs that was not available 18 months ago, but thanks to the public health waiver, we can now offer our direct to consumer program, which is ER on demand. So here is a program description. I'll just highlight a few points here. So ER on demand covers the gap from 8 p.m. to 8 a.m. So when physician offices and urgent care centers are closed, the program is run 7 days a week and open on holidays. As I noted in an earlier slide, this program has emergency medicine physicians taking telehealth calls during their dedicated telehealth shift. It's also important to note that we are currently only taking patients who are physically located in New York State. So let's just say if you're visiting from Florida and you're visiting a friend in New York State and you just so happen to get ill over that time frame, you are able to use us as a pathway to help cure you. Access to ER on demand fairly simple. We have a dedicated phone number for patients to call in, as well as a self-scheduling feature through the Northwell app, which I will touch upon in the next slide. February 1st, 2021 was our public launch date, which included a marketing campaign that focuses on paid search terms. So these paid search terms, when you type in something like into Google, it'll direct you to our web page. A little bit about the process. Again, it's very similar. It's easy to plug into our overall NETS arching program. So a patient is evaluated during registration, and if they do meet our high acuity protocol, we have very easy access to transfer them over to an ambulance if that's what the patient wants, or again, as I was mentioning before, call ahead to one of our EDs. So a little bit about our application. So this was a big feature of ours that we introduced over the past several months. So we actually have a tile that lives on the Northwell app home screen called ER on Demand. Important thing to note here that this ER on Demand tile is not activated during the day. It's only activated from 8 p.m. through 8 a.m., which is our hours of operation. As the patient schedules, they're going to be navigating through several screens. One of our screens that we have is an informational screen, which gives them some detail about ER on Demand. And I think one of our more important screens is our exclusion list screen, which helps guide the patient to the appropriate care they need. So if they realize that they're calling and one of their ailments is listed over here, we're trying to tell them you may not be appropriate for telehealth. You might need to seek care, go to the ER, or call an ambulance. So here's some of the ER on Demand metrics that we do track. The metrics you see here are slightly different from the data I just previously showed, where this is strictly focused on ER on Demand. A large portion of this population trickles in on the weekends as expected, but we do see a steady number of ER on Demand cases per day. And that average number of cases per day has also steadily increased, where in February, we were averaging about 2 patients a day. And as you can see here, we've doubled. We're almost seeing 5 patients actually on the weekends per day, which is, again, continuing to rise each month. So, of course, our work is never done. We are constantly looking for new innovative ways to drive our patient population and volume. So I'll hand it over to Sarah just to kind of take you down that path and dive into this a little bit more.
Thank you, Joe. So, as Joe mentioned, we have been growing drastically since we turned NETS on in January of 2021. And we're almost like a perfect stair step there. So we've been growing at about 20% a month, with the exception of June. So I want to talk about June for 2 reasons. One is that it was the end of our marketing campaign. The second was that it was the month of reckoning with our senior leaders. So when we turned our marketing on in February, our senior leaders had agreed to give us until June to decide whether or not NETS was going to be a viable program, something we wanted to do a 2022 budget for. So we're good, we're ramping up, everything's working really well. We are working hard at getting that volume in so that we can show that we have eventual profitability. And one of the big expenses that our program faced was that paid search term campaign. So when we knew it was going to be up in mid-June, we decided to let it expire, see what happened. If the program, now that it was more consistent we're consistent daily volume and growing, what would we be okay without the volume, without the marketing? And as you can see, we were not. We saw some cases come in that were patients who knew about us already, had used us or heard about us from word of mouth, but clearly we needed that marketing if we were going to continue. As you can see, we did get the green light to move ahead to continue with the program and build a 2022 budget because we have data from July, August, and September. And part of that is the paid search terms. We've actually expanded our reach out into Suffolk County. So we're now if you Google for urgent care or virtual care or telehealth between the hours of 8 p and 8 a in Manhattan, Nassau, or Suffolk, hopefully we rise to the top. But anyway, we spent this year being really focused on volume. So I want to talk about how else we've been trying to increase our volume because the paid search terms are effective but expensive. So we've also leaned into social media, which we can thank our summer intern for. As we were all trying to think about how do we get into people's homes, he said, well, you get into their phones. And so I encourage you to follow us on Instagram. Our Instagram handle is there. Our Instagram is really supposed to be friendly and open and a way for potential future patients to see get information about our doctors, understand our process a little better, and just sort of become a staple in what they think about when they think about how to get urgent or emergent care. We're also, next slide. We're also continuing to build on that. This is on the slide that Joe showed you earlier. So all these existing partnerships that we already have, we want to obviously maintain them and then grow beyond them. So in terms of maintaining those partnerships, we the administrative team on this phone, as well as a few others, realized that we couldn't maintain our day jobs because we all have other things we're responsible for, grow this program and continue to maintain the partnerships of all of these different stakeholders. So we have a few physicians who really wanted to put their administrative leadership hats on as well, and they have become the partners to these programs. So we've divided them up. Your stripes are our internal stakeholders, your solids are our external stakeholders, and there is now a physician who's responsible for those external relationships and one for the internal relationships. And something that's been really mind-blowing for me, but important, is that I always look at this as an administrative responsibility to maintain these partnerships. But in fact, now that the process is built, what these leaders need is physicians to help deal with the nitty-gritty, the particulars of people who are being seen, and questions that they have. They don't need to see me, so they would much rather see our physicians, and that has been a really, really welcome opportunity, I think, from both sides. But as I said, we are adding more partners. So, and we're now including these physician leaders from the get-go. So they're now part of building those relationships as well, which I think is great. We are getting into ambulatory offices as an after-hours opportunity for patients who are trying to seek care when the doctor's offices are closed. We're working with businesses to be an option for employees who are in the office and might want to go to urgent care but don't have time. They can see us via telehealth. And then we're also working with our inpatient teams to put our information on the discharge instructions so that patients who are leaving the hospital have a physician outlet for questions if they need it, the goal being to reduce 30-day readmits. So again, like I said, this first 9 months of the year has been focused on that process, which you heard about from Melissa and Joe, and also on volume, just trying to show that we can be viable from a numbers perspective. But we want to be more than just a COVID program. We want to be sustainable. We want to move into the future as nets beyond the pandemic. We hope that there is a beyond the pandemic. So we're being very hopeful. So I want to look at what those other challenges are beyond just numbers. So the first is patient interest. Right now, people see us because this is where they're comfortable. Are they still going to be comfortable and looking for us when they are bopping around outside of their homes? Second is the insurers. As Joe mentioned, they love us right now because seeing our physicians via telehealth is cheaper than seeing our physicians in the emergency room. But we expect that down the line, they will start to negotiate a bit differently once telehealth becomes a more common delivery method. We also are actually managing this now, which is dealing with those outpatient specialist CPT codes. There's codes for new patients and codes for existing patients. And about 50% of our patients right now are new. So we're getting fantastic reimbursement off those new patient CPT codes. But as they become established with us, then we actually get a lesser reimbursement, which does not value the service that our physicians provide, because your UTI last week is a completely different problem from your sprained ankle next week. So we are working with the payers to try to figure that piece out. We're also expecting increased regulation of telehealth as the waivers end, and telehealth, we hope, becomes a sanctioned option for people to use for their care. We expect there'll be additional regulation, both from a payment perspective, but also from a delivery perspective. We, as I mentioned earlier, are working with our organization to become and stay viable. And right now we are a startup. We are earning revenue, but we are not profitable yet. So the organization is investing in us in the startup, and we hope that they will continue to see us as thoughtful innovators and continue to invest in us. But that's a potential challenge as well. And then finally, the obvious one is competition. Everyone is going into this market. And how, so we want to figure out how we differentiate ourselves, which brings me to how do we do that, and how are we trying to do that? The first thing is maintaining the relationships with the teams that we have worked with so far in the last 19 months. So as Melissa mentioned, there's no playbook for this. We'd never done telehealth in this space before. And some of our teams had worked in telehealth previously across the health system because of doctors' offices sort of wading into this environment. But no one had truly done it in this sort of all-encompassing fashion. So we are incredibly grateful to all of these other teams that are part of Northwell, who have helped us. Some have just totally bought into the program. Some I think we annoy, but they have all given their time and thought and expertise into an avenue that they know potentially little or nothing about. So we're incredibly grateful for that, and I think that will be the key as we move into these other challenges and overcoming them. So in terms of market differentiation, this again goes to building more partnerships. I keep saying to these guys, we're going to have to send out a lot of fruit baskets at Christmas, because we've got a lot of new friends. But our newest friend is our laboratory team. So they are partnering with us right now to actually make it possible for our physicians to order lab tests that can wait 24 to 36 hours to get resulted, so that patients can sort of finish their loop with us. If they need big labs done, if they need a full workup, we're sending them to the ED, or we're saying go to your doctor's office. But if it's something small, something appropriate, even like a strep test, where we could have it done and result in 24 hours, and there's no risk to the patient, then we're happy to do it. So actually, the most challenging piece of this was setting up a closed loop communication between a group of doctors. Right now, we have our ordering doctor might be ordering at 2 o'clock in the morning, and at 2 o'clock the next afternoon, when the result comes back, it's very likely that it will be a different doctor on. So we need that person to receive the result. So that's actually been quite a challenge, but we hope will be a real value add for our patients. They'll also be able to, down the line here, have our lab fly service come to their home if they prefer to do their blood draw at home. We're hoping to do the same thing with radiology down the line. In our online medical control practice, which is part of the NETS service offering, we're looking at EKGs in the back of ambulances. So we hope that will just be the start of our ability to use peripherals to learn more about our patients, even using our watches to do some of that vitals tracking. Because right now our physicians are doing an amazing job of assessing the patient via telehealth, but they are not able to get some of that reliable vitals information they could from different technologies. And then finally, this last one, ambulatory communication, is not about money, it's about being a part of the continuum. So we believe that to be viable and sustainable, we also need to find our place within the network of care. And right now we're working to figure out how most seamlessly to communicate with patients in the ambulatory setting, whether that's PCPs or specialists that we're referring to. We don't want to be outside of the continuum. We want to be helping patients get the care they need when they get it, and then help them move on to the next point of care that is appropriate for them. And so that communication piece, I think, will help patients, but also help physicians who are out there, who are all part of our community. And then we're also looking to not just differentiate, but also improve the process we have. So you've heard from Melissa and Joe, we're just iterating. We're changing all the time. And we want to keep doing that. So we're collecting lots of data in REDCap. And we actually have an admin fellow starting on Monday who is going to get a really big project of diving into this data. I have about 100 questions for her to answer for us. But those questions are going to help us understand, and we have very good understanding, but help us really understand where are the points that slow patients down in the process. And then we got to talk about how do we smooth those over? Where are the points in the process that are really slowing down our physicians? Let's dig into those. And then we also want to take this information then and apply it to every new partnership that we're creating so that everyone is getting the benefit of that experience we've had over the last 19 months. We're also using the data of feedback, both from our patient experience surveys and from our physicians themselves. So a lot, it's all hardware, software stuff from both of these groups. So from a software standpoint, we want to be able to operate our telehealth platform at varying internet speeds, because right now we do experience some challenges with folks who don't have high-speed internet easily available, and we want to ameliorate that. We want to be ready for anyone who comes to us, regardless of their ability to pay and also their ability to access the internet. We also want to improve, that this actually leads into, we want to improve video resolution so that it's easier to see our patients for our physicians. And on top of that, I thought this one was particularly interesting and really important, which is our physicians have asked that they would like in our next iteration a chat function where pictures can be sent securely back and forth, so that a patient could take a picture of their dermatological issue and send it. So the resolution is a lot better on a still versus a moving image. So those are the kinds of things that we're getting feedback on, and we love it. Additionally, our physicians want multiple screens, which I remember when we started, I said, I don't know if they're going to need multiple screens, but that's just expensive. They're running like 6 programs at a time, as Melissa showed us. They could have 10 screens if they want. So that's something we're working on in that 2022 budget as well. But finally, when we think about how we're going to be successful in the future, we have a super secret ingredient, which is these guys. This is our five of our 12 physicians. And like Joe said, there's only 12 of them. We keep this group small because they are the leaders in this program. They want to have the best experience for their patients that they possibly can. And so we keep this group small because we want them to have all the buy-in in the world. This isn't Melissa's program or Sarah's program or Joe's program. This is all of our program. And at 3 o'clock this afternoon, we will get on the phone for our bi-weekly team meeting, and these guys will talk for probably 2 hours. They will share their clinical experiences with each other because they weren't trained in telehealth. So they're all learning and then sharing, and it's fantastic to listen to. They'll share the really cool cases they've caught. Somebody got a brain bleed one time, which did not sound like a brain bleed when the chief complaint came through from the paramedic. They caught a common bile duct stone. There's actually, I think, been 2 of those. So in addition to dealing with the UTIs and the appendicitis and the rashes, they're also catching some really important things that people were trying to minimize. So they love to share that information with each other. The other thing that is really amazing about this group is that they are tech support in the middle of the night. So if the patient has an issue, the doctor's just gonna getting online. Doctor's just gonna call them and say, "Hey, let's figure this out." And they have amazing patients, but it's because what they want more than anything is to get that patient on the phone and have a real interaction with them. So it could be, worst case scenario is they don't do a video interaction. They do just speak on the phone, but these guys will not rest until they've spoken to the patient and the patient has a plan of care. And that speaks to the dedication of our team. And so we love them, and we will bend over backwards to create for them the right process so that they can go out and do the good work. And with that, we will close. thank you for being with us today, for hearing about NETS and ER on demand. You are welcome to use these links when you get the deck to read a little bit more about us, and please feel free to shoot us email if you have questions. But for now, we are happy to take any questions that you have.
Thank you, Sarah, Melissa, and Joseph. This presentation was fantastic. I do encourage any attendees who have questions to please place them in the chat box before we wrap up. A question that did come through from the AHI team that I'll ask is any advice that you may have for smaller health systems. In particular in our rural community, the health systems tend to be smaller scale. If a health system was looking to implement a program like this, what would be some advice that you might have?
Smaller, honestly, is better. Get a couple people like this, this team on the phone. There's many other people that are involved, but keeping it small means you have sort of these ongoing conversations. So you're actually, I think, in a really good place. But it's about coming up with a process that is manageable with the technology that you have. Build with the popsicle sticks and the hot glue gun that you have. Don't go try to do something crazy. At least that's been our experience. But also, get the word out there. People are excited about telehealth. So I think the more, if it's something that you want to do, get it into the hands of your physicians all over those small systems so that they can share it with their patients. Melissa or Joe, anything to add?
I would just add that you also want to be very selective in the group that you put together to focus on a program like this. So Sarah just spent a lot of time explaining our physicians, and she's right. They really are our secret ingredient. But I think, the reason why we're successful is that they're nimble, they're agile, they want to help, they want to be tech support, they want to be the doctor that treats you, they want to follow up and make sure that you're doing okay. But you really do need to form a team that believes in the mission that you're trying to achieve and is willing to go the extra mile to get you there.
There's actually a couple of our physicians who are on the line right now. So if you want to see dedication, that's it. They're bought in.
Yep.
Thank you. And I know that you included your email addresses in the final slide, and that will be up on the summit page by October 1st, if anyone has any additional questions. But I think for now, everyone gave such a thorough presentation during this session. I don't see any other questions coming through. I will just ask if the three of you could check your direct messages to see if any questions came through to you directly.
All good.
Okay. All right, then I think we can wrap up this afternoon session. So again, thank you to our presenters and to our attendees. And we will see those of you who are attending the 2 o'clock session in a short while. So thank you, everyone, and have a good afternoon.